Hi everybody and welcome to our module on the prostate. The prostate is a round gland that sits at the base of the bladder. If you look at this picture on the top right side of the screen, the bladder is shown here. The prostate is a round gland that sits just at the base of the bladder. In addition, the prostate is anterior to the rectum. You can also see that in the picture. This is the rectum and the prostate is just in front of it. This means that on a digital rectal exam, you can palpate the prostate through the wall of the rectum, and this will be important when we talk about the diagnosis of certain prostate conditions. In addition, the prostate encircles the urethra. Shown in this picture at the bottom of the screen here is the prostate gland, and you can see the urethra running through it to connect to the bladder. The job of the prostate gland is to produce prostatic fluid, which is part of semen, and it is stimulated by androgens, and that'll be important later when we talk about therapies to block stimulation of the prostate gland. Let's start by talking about acute prostatitis, which, as the name implies, is acute inflammation of the prostate. This is usually bacterial. In older men, the organisms that cause this infection are similar to those that cause cystitis or a bladder infection. E. coli is the most common, but you can also see infections from Proteus and Pseudomonas. In sexually active younger men, this infection is sometimes caused by sexually transmitted bacteria, so this could include Neisseria or chlamydia. Many of the symptoms of acute prostatitis are similar to those of a urinary tract infection, and you can think of acute prostatitis as a variation on a routine UTI. In acute prostatitis, there can be symptoms of generalized inflammation like fevers, chills, and malaise. There may be dysuria, which is painful urination, and frequency, which is voiding frequently. The urine may be cloudy from the presence of white cells and bacteria. But then the main feature that distinguishes acute prostatitis from an isolated UTI is on digital rectal exam, the prostate will be edematous and enlarged. It's often described as boggy, which means swollen and like mud. In addition, the prostate tends to be exquisitely tender, so when you palpate it with your finger on digital rectal exam, it causes a lot of pain to the patient. And then because this is basically a variation of a UTI, the urine should have the same findings as in a urinary tract infection. There should be white cells in the urine, and a urine culture should grow bacteria. It turns out that antibiotics don't penetrate the prostate gland very well, so some men develop chronic bacterial prostatitis, where they have chronic or recurrent prostatitis symptoms like I described on the last slide, and ongoing evidence of bacterial infection in the urine. There's also a chronic abacterial or non-bacterial form of prostatitis. Men who have this condition have symptoms of prostatitis like pain with urination and difficulty voiding. They also tend to have chronic pain in the pelvis and the low back. Sometimes there's blood seen in the semen, but no bacteria are identified on urinalysis. The etiology of this condition is not clear. It's sort of like a variation on irritable bowel syndrome of the GI tract. These men have chronic evidence of prostatic problems, but their workup shows no obvious etiology, very difficult to treat. Now let's talk about BPH, which is benign prostatic hyperplasia. This is an age-related condition that's very common in men over 50. They develop hyperplasia of the stromal and epithelial cells in the prostate gland, and because the urethra runs right through the middle of the prostate gland, when the prostate grows in size, this results in partial or complete urinary obstruction and difficulty voiding. Importantly, this is not a premalignant condition, so in many other tissues in the body, when hyperplasia occurs, that's a risk factor for developing cancer. That is not the case in the prostate. This form of hyperplasia does not lead to prostate cancer in general. So what are the symptoms that patients will complain of when the prostate becomes enlarged with the urethra running right through the middle of it? Well, first of all, men will have hesitancy. This is where they cannot start the urine stream. They also may have frequency. This means that they're going to the bathroom frequently, and this is because of incomplete voiding because of the obstruction to urine flow. Many men also develop dribbling of urine, all that bearing down to try and push urine through the prostate gland over time leads to problem controlling the urine flow, and men can have dribbling of urine. The bladder may hypertrophy over time from being constantly full and distended, and rarely this can progress to cause complete obstruction, so men can present with inability to void. Their bladder can be distended, and the kidneys can even become swollen. This is called hydronephrosis, and this can lead to a form of post-renal failure. And then finally, men who have BPH have an increased risk of UTIs. Basically, they're not flushing urine through their bladder normally, so this leads to slow urine flow, and it makes it easier for bacteria to get into the bladder. The type of hyperplasia that occurs in BPH is called nodular hyperplasia, and it gets its name because instead of a diffusely enlarged gland, what you usually see are small nodules of hyperplasia in different parts of the prostate gland. And the places where these nodules tend to develop is called the transitional zone. And in order to understand this, let's review a little bit of prostate anatomy. So there are two ways to describe the anatomy of the prostate. One way is by lobes and the other is by zones. Let's talk about the lobes first. So if you look at this drawing on the screen here, there are two large lateral lobes within the prostate on the outside on the left and the right. Then there is an anterior lobe just in front of the urethra. The urethra is here, and behind the urethra is the median lobe, and then there's an elongated posterior lobe. So that's the way you can describe the prostate by lobes. This is the way anatomists often do this. And if you describe it by lobes, then the places where you often see nodular hyperplasia are in the median lobe right here behind the urethra, sometimes the anterior lobe right in front, and sometimes in these lateral lobes, but usually not in the posterior lobe in the back. The other way to describe the anatomy of the prostate gland is by zones, and when you do it this way, there are three zones: a transitional zone, a central zone, and a peripheral zone. When you describe the anatomy this way, the transitional zone is the zone that surrounds the urethra. That's where most BPH tends to occur, and it compresses the urethra into a slit and obstructs urine flow. The peripheral zone is the outside of the gland, including the posterior lobe, and as we'll talk about later, it is this peripheral zone in the posterior lobe where most carcinomas of the prostate tend to occur. As I told you at the beginning of this video, the prostate gland is stimulated by androgens, and in particular, growth of BPH is driven by the very potent androgen dihydrotestosterone, or DHT. DHT is formed from testosterone using the enzyme 5-alpha reductase. So if you understand this, then it's very easy to imagine that the 5-alpha reductase inhibitor finasteride is useful for treating BPH. Now, this is going to inhibit synthesis of DHT, and it's going to take time to take its effect. So this isn't a good therapy for a man who presents with acute obstruction of the bladder. However, for a man who has mild to moderate BPH symptoms, this can allow slow onset symptom relief over time by inhibiting the production of DHT. Shown on this slide are some other treatments for BPH. Alpha-1 receptor blockers are often used. There is some smooth muscle in the prostate, and there's also some at the neck of the bladder. So these drugs cause smooth muscle relaxation, and that makes it easier for urine to flow. The alpha-1 blocker that's most commonly used is called tamsulosin. This is said to be uroselective because it predominantly blocks alpha-1A receptors, not alpha-1B receptors. Alpha-1B receptors are found in the periphery, and when you block those, you lower the blood pressure. That's why alpha-1 blockers are sometimes used for hypertension. But if you want to treat BPH and not lower the blood pressure, then tamsulosin is useful because it only blocks alpha-1A receptors, so it causes less hypotension as a side effect. Phosphodiesterase 5 inhibitors can also be used in some cases. These drugs are more commonly used to treat erectile dysfunction, but they can be used for BPH. They also cause smooth muscle relaxation and help BPH in a similar manner to alpha blockers. The one PDE5 inhibitor that's approved for BPH is called tadalafil. And then finally, surgery is often done by urologists for severe BPH. The classic surgery is called a transurethral resection of the prostate, or TURP. In this procedure, the surgeon inserts tools through the urethra to try and minimize the size of the prostate and the obstruction at the level of the prostate gland. I'll finish this video by talking about prostate adenocarcinoma, which is the most common form of cancer in men. It is the second most deadly form of cancer in men, second only to lung. It tends to occur in older men, usually over 50 years old. As we discussed earlier, you can describe prostate anatomy either by zones or by lobes. If you do so by zones, then prostate cancer usually occurs in the peripheral zone of the prostate, which is the outside portion of the prostate. In terms of lobes, it classically occurs in the posterior lobe, which is this elongated lobe at the back of the gland. And remember, the posterior part of the prostate is right on top of the rectum. The rectum's right back here. What this means is that since prostate cancer often occurs in the posterior lobe, you can sometimes palpate a nodule by digital rectal exam in cases of prostate cancer. If we go back to this slide, we talked about earlier how BPH usually occurs in the transitional zone, which is this zone of the prostate lobe around the urethra. In contrast, prostate cancer usually occurs in the peripheral zone, especially in the posterior lobe at the back of the prostate gland. And it's very high yield for you to know the different anatomic locations where BPH and prostate cancer tend to occur. Usually prostate cancer is asymptomatic. Rarely it causes dysuria, and you should understand why it's rare for prostate cancer to cause urinary symptoms, because it usually occurs in the part of the gland that is far away from the urethra, in contrast to BPH. It's often felt as a nodule on digital rectal exam, as I just described. We screen for prostate adenocarcinoma with PSA, which I'll talk about in a minute, and the diagnosis is by a prostate biopsy. Usually it is a transrectal biopsy, often done with transrectal ultrasound guidance. And once again, this is a tie-in with anatomy. Since the prostate gland sits right in front of the rectum here, you can insert ultrasound and other tools into the rectum to get at the prostate gland, and that's how a biopsy is performed. Here's a zoomed-in picture just to make this clear. You've got a cancerous prostate gland here. This drawing shows the cancer in the posterior portion of the gland, which is where it often occurs. That means you can put biopsy tools, including ultrasound tools and needles, into the rectum and use the rectum as a way to get at the prostate and take a biopsy. Let's talk about PSA, which is prostate-specific antigen. This is an androgen-regulated substance that's found in semen, and it's produced by normal and also malignant prostate tissue. The level of PSA can go up in BPH and prostate cancer, and for this reason, it is sometimes used as a screening tool for prostate cancer, but you can imagine how complicated this is because BPH is very common in older men, and it's a benign condition. Prostate cancer is a malignant condition, so since both conditions raise the level of PSA, it's hard to tell one from the other. Sometimes PSA is used for screening, but this is controversial because in some studies, the early detection of prostate cancer has not led to a survival benefit, meaning the PSA led to detection of cancer and treatment, but it may not have extended the life of the man in whom cancer was diagnosed. If you do use PSA for screening, the normal and elevated values are shown on the screen here. 0 to 4 is a normal value, 4 to 10 is elevated, and greater than 10 is significantly elevated. This is when it becomes highly suspicious that cancer may be present. When you do your clinical rotations, you'll find a lot of older men have a value between 4 and 10, and it's hard to know what to do with these numbers. So one way to screen a man for prostate cancer is to measure the total serum PSA, as I just talked about in the last slide. Another way is to measure the percent free PSA. So it turns out that most PSA in the blood is bound to protease inhibitors. The two that most commonly bind PSA are called anti-chymotrypsin and macroglobulin. This means that you can measure the percent free PSA versus the bound PSA, and prostate cancer tends to produce more bound PSA. So if you want to screen a man for prostate cancer, one way to do it is to measure the total PSA, as we talked about in the last slide, but also measure the percent free PSA. The total PSA should go up, but because most of that prostate-specific antigen is bound in prostate cancer, the percentage of total PSA that is free will decrease if the man has prostate cancer. Prostate cancer is diagnosed by a biopsy, as we talked about before. The prognosis of prostate cancer depends on the stage and the grade of the tumor. So stage is the extent of tumor growth and spread, including whether or not metastases have occurred. Grade is determined by a pathologist using the Gleason system. So pathologists are trained to look at biopsy specimens of prostate cancer and determine a Gleason score based on the biopsy findings. This depends on whether there are well versus poorly differentiated cells. They won't ask you to grade a Gleason score of a prostate cancer on your step 1 exam. That's a very advanced skill. You should be aware that this is the name of the system that is used to grade prostate cancer. And here's an image of prostate cancer from the web. It's unlikely they'll ask you to recognize this on your boards because it really doesn't have many specific findings. There's lots of this pink stromal tissue here and then lots of glandular tissue shown here. Metastasis of prostate cancer occurs hematogenously, and classically the cancer spreads to the spine and causes back pain and an increased alkaline phosphatase level. There are two general types of bony lesions caused by cancer mets. The first type is called osteoblastic. The second type is called osteolytic. You should be aware that prostate cancer is the classic cause of a purely osteoblastic lesion. By osteoblastic, what this means is that the prostate cancer metastases lead to deposition of new bone. And this is in contrast with osteolytic lesions, which are metastases that lead to breakdown of bone. Prostate cancer is the classic cause of an osteoblastic bone lesion, and multiple myeloma is the classic cause of an osteolytic lesion. Most types of cancer metastases cause a mix of both types of lesions. Prostate cancer is special in that it usually causes a purely osteoblastic lesion, and multiple myeloma usually causes a purely osteolytic lesion, and that's why these two cancer types are high yield for you to know for step 1 of your boards. On the left side of the screen is an osteoblastic lesion like you would see in prostate cancer. Notice the white from new bone deposition. On the right side of the screen is an osteolytic lesion. Notice that the lesion is black because bone is being broken down. Here's another example from the web. This is a CAT scan. Notice this white lesion in the bone of the spine. That's osteoblastic activity making the lesion white, and that's what you see in prostate cancer. Prostate cancer is often treated with surgery. In addition, there are some medical therapies that can be used, and the idea here is that these medical therapies block androgen activity because androgens stimulate the prostate gland and they also stimulate prostate cancer cells. Flutamide is a competitive inhibitor of androgen receptors, and that can be used in prostate cancer. And then leuprolide is a GnRH analog. So recall that the hypothalamus stimulates the pituitary gland to release FSH and LH by releasing GnRH in a pulsatile manner, and that causes the pituitary gland to release LH and FSH, which can drive androgen production from the testes. If you administer leuprolide in an intramuscular or subcutaneous fashion, in other words, not a pulsatile fashion, then it will actually suppress FSH and LH release. FSH and LH are only released when GnRH hits the pituitary in a pulsatile fashion. If there's constant administration, this will suppress FSH and LH release, and that will lead to less androgen production from the testes. And that concludes our video on the prostate gland.